Hello, everyone, and welcome. It's a privilege to be here today to introduce you to the Journal of Obstetric, Gynecologic, and Neonatal Nursing, otherwise known as JOGNN, and to highlight an essential topic that affects every stage of women's life, mental health. My name is Joyce Edmonds, and I currently serve as the editor-in-chief of JOGNN. JOGNN is the scientific journal of the Association of Women's Health, Obstetric, and Neonatal Nurses, or AWON, the largest nursing organization dedicated to the care of women and newborns in the United States. The mission of JOGNN is to advance the health and healthcare of women, childbearing families, and newborns across all settings through the bi-monthly publication of peer-reviewed nursing and interdisciplinary scholarship. The journal is widely recognized for its commitment to high-quality interdisciplinary scholarship, ensuring that nurses, midwives, and researchers have access to the latest insights that drive excellence in care. Today, I'm so pleased to announce JOGNN's first ever special issue, Women's Mental Health Across the Life Course, that was the result of the vision and work of guest editors Dr. Shannon Simonovich, Kelly McLaughlin-Bell, and Beverly Rosman. This unique issue of JOGNN underscores the pivotal role that nurses and healthcare professionals play in fostering optimal mental health for women across the lifespan. Through rigorous research, a compelling case study, and diverse perspectives, it shines a spotlight on the critical mental health challenges women face. These works not only contribute to the scientific dialogue, but also translate into real-world strategies that clinicians can use to improve patient care. JOGNN authors and audiences have long recognized that mental health is a critical component of women's well-being, not just in the perinatal period, but throughout the lifespan. From adolescence to menopause and beyond, mental health challenges such as depression, anxiety, trauma, and stress-related disorders affect millions of women worldwide. Understanding and addressing these concerns is essential to delivering holistic, effective, patient-centered care. I encourage all of you to explore JOGNN's latest issue and engage with the research that is shaping the future of our field. This entire issue is available open access for download from the JOGNN homepage. I thank you for your dedication to advancing care and look forward to the discussion that this special issue will inspire today. I'd now like to introduce our guest editors, Dr. Shannon Simonovich and Dr. Kelly McLaughlin-Bell. Dr. Shannon D. Simonovich's program of research utilizes the life course approach to study maternal mental health and intergenerational outcomes. She is a clinical associate professor in the Department of Population Health Nursing Science at the University of Illinois, Chicago College of Nursing. In addition to her role as a member of JOGNN's editorial advisory board, she serves as a governing council representing public health nursing in the American Public Health Association, and as she's a member of the executive board for the North American Society for Psychosocial Obstetrics and Gynecology. She is the author of more than 50 peer-reviewed publications. She's the mother of 3 young children and is passionate about intergenerational mental health wellness and mentorship of the next generation of women's health scholars. Welcome, Dr. Simonovich.
Thank you, Dr. Edmonds.
Next is Dr. Kelly McLaughlin-Bell, who is an assistant professor at UT Health San Antonio School of Nursing. As an esteemed nurse scientist, Dr. McLaughlin-Bell's program of research centers on policy-focused implementation science to reduce health disparities and improve health equity for families at the intersection of reproductive justice and substance use. Through a practice lens, she became aware of how discriminatory health and social policies often take advantage of, rather than support, historically marginalized people. Thus, Dr. McLaughlin-Bell is currently examining how discrimination, intersectional stigma, and implementation of mandatory reporting policies affect access to and utilization of obstetrical care and treatment services among pregnant and parenting people with a history of substance use. Most recently, she was selected as a 2023 fellow for the Association of Women's Health Obstetrics and Neonatal Nursing. Welcome, Dr. McLaughlin Bell.
Thank you so much, Dr. Edmonds.
I will now turn it over to you to introduce the webinar and the structure of our time together and tell us more about this special issue.
Thank you so much. So our goal today is to feature some of our incredible authors that we have in this special issue. So we're going to be structuring this event as follows. We're going to talk a bit about why we put this special issue together. We're going to have 4 different presentations by authors whose work is featured in this open access special issue, immediately available for download. And then we're going to have a moderated discussion with the authors that we have here today. So women's mental health across the life course. We worked with our colleague, Beverly Rossman, the group of the 3 of us, to really examine what area JOGNN could focus its first ever special issue on that would impact all of the nurses and all of the readers that we have that work in OB spaces, perinatal spaces, neonatal spaces, and in gynecological spaces across the lifespan. And one chronic issue that we see come up time and time again across women's life course that really needs a great deal of attention, funding, support, and change at the policy level is women's mental health. So when we think about women's mental health across the life course, we think about key critical periods in a woman's physiological development that impacts her mental health. Those can include menarche, sexual initiation, pregnancy, menopause, and end of life. Mental health conditions such as depression, anxiety, PTSD, and others influence outcomes for women and their families at every point across the life course, and that's what this issue is really meant to bring to light.
I will also add that as we look at women's mental health across the lifespan and life course, we really want to consider risk accumulation. And so this means, how are women being affected from the very beginning of life at birth, and how does that risk accumulation occur over time and affect their chronic and mental health conditions? And so we have a very broad array of topics that are presented within the special issue, which we look forward to sharing with you here shortly. So now we will go ahead and move into our selected speakers. Our first speaker today will be Dr. Nahida Nayez Ahmed. She currently serves as the Chief Medical Officer at Sakina Mental Health and Wellbeing Services and is an American Board Certified Psychiatrist. She leads key mental health initiatives in the United Arab Emirates, holding leadership positions and integrating services throughout Abu Dhabi's primary health network. Welcome, Dr. Ahmed.
Thank you, Dr. McLaughlin Bell. I'm sorry, am I going to be managing my slides, or it'll be managed on your side? I think I missed that. Okay. Thank you, everybody, and thank you to the editorial team for giving me an opportunity to speak tonight. It was a privilege for me to work with the team, some of the members here today, on this special research study exploring the mental health experiences of Muslim American women during the perinatal period. There was a lot of insight and valuable insight that came out of the study, and I'm really delighted to be sharing that with you. Full disclosure, I'm way past my bedtime, so if I go a little bit loopy and delirious, and just so forgive me. Maybe we can move the slides to the next. So this was our study that came out this year in October, and as I said earlier, it was to explore the experiences of American Muslim women in perinatal and during the perinatal, and how their mental health experiences have been. We know majority of the women who have moved to US or have lived there as a second or first generation are still very much integrated into their cultural and traditional background. So their experiences are quite diverse from what you would anticipate from the majority or the mass experiences that happen across the board for perinatal period. And this was our way of looking into what needs to be mapped into the deficits, or what deficits are there, first of all, to recognize and to help and provide help accordingly. So the way this study was conducted was that it was through the phone interviews. There were a bunch of interviews done with Muslim women who volunteered to participate after having received a circular through social media and various channels. And before I dwell into the details of how we proceeded, the conclusion of this research was that there needs to be a lot of work to be done when it comes to the mental health literacy, when it comes to screening and providing follow-up and access to care for these women. Next, please. These are my disclosures, and for today's content, I have no financial benefits. So before diving into what we saw, let me explain to you how depression is perceived among Muslim minorities in the US and the Western world for most part. Now, I'm speaking from the Muslim majority country, so it's different from where the study was conducted, obviously, but the mindset remains the same, especially because the cultural background and the traditional backgrounds are globally the same when it comes to Muslim population. So there is a lot of reliance on community and families and the close-knit extended families also in many cases when it comes to mental health support or psychosocial support, which for most part is known to be protective. But unfortunately, when we look into women who have migrated or who are either first or second generation in the US or in the UK also for that matter, these are women who are not necessarily surrounded by a close-knit family or do not have that fabric of the support system that would have happened if they were in their native countries. Although the majority of the women who participated in our study were US-based, and they hold the US nationality, which means they've lived there long enough. Yet there was the disconnect from their traditions, the disconnect from their social society, and the bigger, community was quite evident in the responses that we got. Muslim women are not immune to depression and anxiety, just like any other nationality or racial ethnicity. I think by far they are a little bit more, if I may say it so, they're more vulnerable to it because of the lack of literacy, lack of understanding of mental health issues, lack of acceptance that this is a problem and I need to deal with it, so they tend to suffer alone, and also partly because of the lack of community and the support. So one of the things that Muslim women tend to endure without speaking up is also it has to do with the cultural expectations from them, that if you are going to be a mother, you're supposed to be a superhero, you're supposed to tolerate and endure every kind of hardship, you're not supposed to complain, this is a huge gift that has been bestowed upon you and you're supposed to be grateful, and so on and so forth, which I think women do have been perceived when they go into this maternal journey from across the world, but I think a lot more so among Muslim women, because accepting or acknowledging that there is any kind of difficulty is a matter of shame or stigma that you're not a good enough mother. And there has never been a targeted a study done on Muslim American women or even Muslim women in this region, for that matter, to say what were the perceptions, what were their attitudes, and how much was their knowledge for when it comes to maternal mental health. And this study gave us a little bit of insight into what was missing. Next, please. So, as I said, the purpose of the study is pretty clear. We wanted to get an insight into what are the gaps there, and how it was done is by one-to-one phone interviews. There was a flyer exchanged on social media channels, and respondents of the flyers were engaged in a phone interview. All the interviews were standardized, and once the interview was completed and transcribed, there was a verification and a thematic analysis was conducted to determine what were the common themes or the emerging themes from these interviews. Next, please. This was the flyer that was circulated, and we had quite a good response, more than what we had anticipated, in fact, because this was circulated through social media and the community groups in the social media communities where more Muslim women or moms were frequented. Next, please. This was some of the results of the study. As you can see, majority of them held a U.S. nationality, so they were U.S. citizen, which means they've lived there long enough. Quite a few of them were well educated, either master's or bachelor's degree, so they come from an educated and backgrounds. When we say white Muslim women, most of the Middle Easterns are classified as Caucasian, so it should not be mistaken for the actual whites of the American community, who are probably converts. But this is mostly the Middle Eastern and the North African community that is also recognized as white on ethnicity and race. Next, please. So what we realized from the thematic network analysis was that there were some emerging themes coming out of each and every interview. For example, there was more of education that was requested, more of awareness, more of engagement in terms of the mental health literacy surrounding women in pregnancy and their mental health changes, and also access to care. So majority of the times this is an evolution of the health status, and sometimes people start with mild to moderate and then progress into severe, and perhaps postpartum that gets even worse. So putting early access to care, putting early access to education and resources to understand what's happening goes a long way in mitigating possible adverse events. The screening that is so often practiced is not necessarily a common practice among the Muslim communities, or Muslim women don't have the access to the regular screening, be it in perinatal period or otherwise. So, for example, here in the UAE, in our United Arab Emirates in Abu Dhabi, we've tried to promote APDS screening in the perinatal period, but back in the US, when we did the interviews, it was not a norm for individuals to go through the screening protocol and have access to early referrals. There was this perceived stigma when it comes to maternal and child bonding. Because of mental health experiences, a woman would not feel much engaged, but then that would be perceived as something deficient in the faith or not being grateful enough. That's a common theme that people tend to associate with women who say that they are unwell, but the lack of care or the lack of treatment and intervention also worsens that maternal and the child bonding, because then the child is seen or becomes more of a stress and a strenuous engagement to deal with the parenting practice, which should have been otherwise a joyous occasion. Again, faith culture has a huge influence on how women perceived mental health within the Islamic religion itself. There are certain recommendations when it comes to Sunnah. You have to follow some rituals. There are first 40 days when women are not engaging in prayers as much, because they're perceived to be impure or unclean. So they have to go through that whole period of not possibly meditating or praying, which would have otherwise suit them. Also, the lack of family support, as I mentioned earlier, which again brings a lot of positivity into their lives and support into their in their challenging times, was unavailable, which begs that we need to provide more resources wherein moms can connect with each other, individuals who have migrated and who live in isolated communities, who don't necessarily have a huge network, and connect with each other while they can, and build that support system. Next, please. Now, from the healthcare professionals' perspective, again, for us, I think what we recognize from this study is that we need to be more mindful about people's backgrounds and diversity. So therefore, acting proactively and asking for the right questions and screening and integrating this mental health, screening programs into community-based arenas like mosques and community houses where Muslim women frequent, especially during their pregnancy, and engaging community leaders when it comes to just awareness. So these were as a snapshot of what we found, and I think there's a lot of work to be done there. Next, please. And I think it's a good indication, and it's a good start to a problem that can be stopped and it can be nipped in the bud, because there's, as we all know, that screening and early interventions go a long way when it comes to mental health issues, and also providing the support which especially is needed in postnatal period by actively and participating in mental health interventions in perinatal period. Thank you. Next, please. So again, one of the other challenges that we came across was the language and cultural barriers. So majority of the times when these screening tools are applied, even here for that matter, they don't necessarily speak the same language as when it's translated. For example, I can give you the simplest example from PHQ-9 when we talk about having lost pleasure or anhedonia, which is basically not enjoying things, literally translates into having lost pleasure, which a reader perceives as loss of libido. So it's not the same thing, and we need to tailor and customize these questionnaires to suit their language and traditions, and perhaps their understanding also, or do a more education when it comes to the symptoms of depression, symptoms of perinatal mental health challenges. Next, please. So again, as we mentioned earlier, the family structures are very protective, but they can also be, impairing or hurting people more, because there is this conflicts and the domestic violence, that the abuse or emotional abuse that goes into the families do not necessarily always surface, especially in this population where the attitude is always to be submissive and to give in. So when I've practiced in my brief time in the US, I've noticed that when we compare the Muslim women to let's say the women who have been born and bred and raised in the West, it's not the same when it comes to the acceptance of the abuse. Muslim women don't tend to necessarily acknowledge and report the abuse, especially also maybe because of the lack of the social support that they have. They don't have families to fall back on, or a big circle of friends that they can fall back on. So in the fear of isolation, they tend to endure it. So having to acknowledge all of this when an individual walks into your clinic or in your practice with pregnancy and from a certain background, you have to dwell into all these questions about, the abuse, the social circumstances that they're coming from, the stigma that they are carrying with them, the cultural background, and the perception of mental health itself. Next, please. Again, it's just a repetition of what was concluded, that there should be more proactive screening for depression. More and more education is required, more and more resource building when it comes to providing the psychosocial support, be it in community-based or through the healthcare system or through the places of work. There has to be a way for outreach when it comes to women from this background. Next, please. This is a snapshot of what we hope to practice here. We have started implementing this. This is our integrated model when it comes to assessing a woman ahead of time. In every trimester, we subject them to the EPDS, which is Edinburgh Perinatal Depression Screening, and follow them up, and then do the prompt and appropriate referral based on their scores. Next, please. This is the integrated model that would be an ideal setting. I know there is a lot of stigma among Muslim community to go to see a psychiatrist, but with the family medicine upskilling and the nurse practitioner upskilling, we can prevent that also before the patient needs to go into seeing a psychiatrist. They can be addressed at the level of primary care and the nurse practitioners as well. Next, please. Well, that brings me to the conclusion. Thank you very much.
Thank you so much, Dr. Ahmed, for your wonderful presentation. Any questions that you might have for Dr. Ahmed or for our other presenters, you're welcome to add into the Q&A, and we will share those with our editor as we move towards the moderated discussion. It is now my distinct pleasure to introduce our second speaker of the day. Karen Tabdina, PhD, MSW, FAA, SW, is a professor at the University of Illinois at Urbana-Champaign. Her research agenda addresses inequities in perinatal mental health outcomes impacting parents and infants. Dr. Tabdina is one of the foremost international experts on perinatal patient engagement, perinatal mental health, racial disparities, and social determinants in maternal and child health. She serves as an elected board member for the National Association of Perinatal Social Workers. Welcome, Dr. Tabdina.
Well, hi. Thanks for the warm welcome, and thank you for everybody who is watching right now and attending. It's an honor to be with you all. Thanks for sharing your time. In the next 10 minutes or so, I want to jump in with an overview of the paper that is now published in JOGNN on the topic of race. Multiple races, so a biracial, mixed race, multiracial people, and their mental health needs during the perinatal period, why disaggregating data is a timely topic and something that we all must strive to do better with. Can we go to the next slide, please? All right. I just want to share the work that I'm presenting has lots of overlapping with lots of funding sources that support this work, but all of the views today are my own. They belong to me, and I'm not putting the responsibility on the funders. Next slide, please. For a quick introduction to this word perinatal, a refresher for this audience. When I say perinatal, I mean a 2-year window. So I mean the point of conception through the pregnancy, through a live birth, and then up to 1 year after delivering that baby is how I am defining perinatal for this work. Next slide, please. I'm also going to use the term race. What do I mean by race? I'm not referring to biological notions steeped in phenotypes, referring to genetic admixture populations. Rather, I'm presenting race as the social construct. So it's the social construct that is a powerful proxy for one's lived experience and shapes our health and wellness, especially here in the United States. This term changes over time. It changes by place. And the terms we have today will certainly be different in the future. Next slide, please. When it comes to the term of multiracial, which is a relatively new term, new-ish depending on your age, it's been about 25 years since the United States Census introduced the concept of selecting 2 or more races. So multiracial is new-ish, but in our nation's history, it's something that we've always dealt with, and there's many policies on the books historically for blood quantums. Anyways, that is a different lecture. For the purpose of today's lecture, I mean multiracial as in self-reporting, self-describing that you belong to 2 or more racial categories. That means introducing yourself as I am Black and Asian instead of I am Asian or Black. So it's the and component, the and. It's the combination of multiple races. Okay, next slide, please. Let's jump into perinatal health. This is a refresher for this audience, I know, but perinatal mental health remains in a crisis. Maternal mortality and morbidity in this country are in a crisis. We are not as healthy as we can be, and we are falling behind many other nations with similar economic structures. Typically, we have about 4 million babies born each year. There were 3.6 born in our most recent estimate of 2023. And the maternal mortality rates have continued to increase. I present maternal mortality because the overwhelming majority of all of the deaths that we are seeing in this country are preventable. And the drivers behind those deaths are maternal mental health problems and substance use disorders that are usually co-occurring or complicated by maternal mental health problems. Next slide, please. The major disorders that we are seeing in this country behind those maternal deaths, behind maternal sickness, of course, come from depression, anxiety disorders, and suicidality. So individuals might make an attempt during their pregnancy and an attempt again in postpartum. 1 in 5 people are going to experience this burden. Now, there are treatments. There are a number of treatments available that work. And in 2025, we're just starting to learn more about non-pharmacological interventions such as yoga, meditation, prayer, exercise, changing one's diet, journaling, etc. The gold standard of first line of treatment are psychotropics. Those are drugs administered to help an individual manage their symptoms and have treatment through remission. These could be SSRIs, mood stabilizers, antipsychotics, and the like. And then psychotherapy. Talking works. In my field of social work, perinatal social workers, we are behind a lot of the psychotherapy that's provided to perinatal people. I put a plug in for Postpartum Support International because they have free trainings that are available and several peer counseling opportunities and groups as well, if you know someone in need of care. Okay, there's a hotline too, TLC Mama. Next slide, please. I just wanted to introduce treatment because if you have a mental health concern yourself in your lifetime, you live with someone, you care for someone who has a mental health challenge, you know that they are not their best when they do not have a treatment that works for them. So it's not that mental health is some sort of sentence, having a mental health burden. No, it's the untreated. So untreated perinatal mental health problems are associated with risk for babies, such as intrauterine growth restriction, low birth weight, preterm birth, etc. They're associated with obstetric risk for mom, such as decreased pain tolerance, increased burden of gestational diabetes, increased experience of a C-section. They present risk for babies. We've done a lot of this work in the global South and low and middle income countries, where we look at untreated depression and impaired bonding and cognitive delays in infants. And then this should go without saying, but science was needed to show us the untreated depression and anxiety during the pregnancy are related with untreated postpartum mental health complications. Go figure. Okay, next slide, please. Within all of this, my work for the past 2 decades is sought to identify how do we put a perinatal mental health treatment pathway in place. Much of my career has been on that detection and assessment side of the sphere, where we're trying to see how do we identify at a population level who's in need of care, who's in need of treatment, and then how do we refer them? That's where we've stopped in terms of my career. It's let's screen them for depression using the Edinburgh postnatal depression screen or the patient health questionnaire. Let's screen for anxiety using the GAD. Let's use a clinical assessment or judgment and look at diagnostic codes. And then maybe we can refer out for treatment. This is not enough, okay? But this is where we are. As you know from several seminal studies, less than half of people will ever receive the 3 words, "How are you?" from a medical exam. No one is going to ask about their mental health condition. With that gap in the perinatal mental health treatment pathway, less than 6% of people in need of care are going to have the full and adequate care that they need for treatment through remission in the postpartum period. And these are long-standing studies. So my work within the space of early assessment, detection, treatment has looked at the disparities, the divergence, and the burden of this disease across populations. Can we go to the next slide, please? With these disparities, we're looking at those early phases, right, of detection, of prevalence, sometimes of incidence, and we're seeing what is the burden of the problem? Are there differences? Are there disparities? And we have looked at, yes, there are differences when we look by place, by either geography, the geographic region, or rural to urban. Yes, we find differences in the burden, where the burden is greater for individuals living in rural settings, which should not be surprising because of the closure of medical facilities and things like maternity care deserts, things like impaired internet access, where there isn't enough bandwidth of internet speed to have a telehealth appointment. Should go without saying. Okay, so we've looked at those things empirically. We've also looked at race. Remember that social construct? We've looked at race. And in several of our studies, we have found that there are differences in the diagnosis, differences in the expression of symptoms, differences in the types of mental health burdens by race. Looking at Black women. In some of our studies, we've looked at Black multiracial women. And looking at Asian women, where the burden of depression is higher and the burden of suicidal thoughts during the point of pregnancy or postpartum are higher. And there have been several follow-up studies and a systematic review on the topic showing that increased burden by race. Next slide, please. So this work fascinates me. What is it about someone's race, how they ascribe when they walk into a clinical setting? What is different? Well, some studies, such as this 2021 paper led by Abby Sidebottom and colleagues, looked at the differences in a clinic that should have had 100% screening rate. So 100% of pregnant women should have been screened for depression, and 100% should have been screened for depression again in the postpartum period. What they found is that there were differences in who was screened, okay? So there was an average of only 2/3 of people being screened for depression, and then some groups were screened more than others. So when we looked at the average and then looked at multiracial, and I'm seeing Native Hawaiian Pacific Islander. Okay, I'm noticing my slide and seeing where things are. We would want the bar to be higher and high among all groups, but we see that fewer proportions of individuals who are racial and ethnic minoritized, racial and ethnic minorities, and multiracial, fewer are screened. So less than average are screened for depression. This work really inspires me to look at disaggregation of data. Next slide, please. So as I highlight in the paper, I highlight several features of the multiracial population and why this is a keen area for investigation. The phenomenon of biracial Americans really surged around the year of 1980. This was coined as the biracial baby boom. This was about 13 years after the Supreme Court ended laws that prohibited two people of different races to marry and cohabitate. My own parents were married in 1972, one black, one white, and they were married against social norms, but it was legal standing in their state of Texas. So this biracial baby boom is going to start in 1980, okay, and it's going to continue to grow. The census shows us that the number of multiracial individuals has gone up exponentially since we've been collecting this data. The current estimate is that 33 million, with the M, 33 million people are from two or more racial backgrounds, okay? This shift is going to continue to increase as the United States becomes more pluralistic, as we continue to grow in racial, ethnic, linguistic, and cultural diversity. Our current records are not, they're not caught up, trying to think of the word for it, but they are not ready to capture the flow, this change in the shift and flow of how people self-categorize and self-select their racial data when completing medical record forms, birth certificates for vital records, death certificates at the point of death. And few scholars have kept pace with this demographic shift in the United States. For our topic of pregnancy and birth, this is so interesting, because we have a large subset of individuals that are now entering midlife on the life course, that have gone through the reproductive phase, and if you think of women now, are entering menopause. And we do not have current estimates on this multiracial population and the experiences that they are having in a healthcare system that is set up for singular racial identities. So this fascinates me. I am not alone in this thinking in 2025 that we need to disaggregate our data to truly understand population health. Next slide, please. And create clinical solutions that adapt and grow with individuals. Now, if race is supposed to be an important proxy for a lived experience, and we know that there are racial differences in the burden of disease, with some racial minority groups experiencing greater burden of disease, such as diabetes. What are the patterns of people who fall in between those racial categories and might have a lived experience that is somewhat in between? This theoretical concept is called a variant approach to population health data, meaning that we have new categories that are emerging that are important to understand for health disparities data. I challenge each and every one of you listening to this call today to think hard, to think critically about your own data, to think through what it means, and to not be afraid of the noise, people say, the noise of small groups that might have small samples, but to think through how your own data and data in the healthcare systems that you interface with can be disaggregated to fully document patterns of health and health outcomes among these new burgeoning groups. Next slide, please. I want to end on a note of organizations to support. This is not in the paper, but these are great organizations doing this work, great places for more follow-up and resources, and I'm sure they will be keenly aware to the topics of multiracial health as we move in and into these decades to come. So thank you for listening, and I look forward to any questions you may have.
Thank you so much, Dr. Tabdina, for a riveting and insightful presentation. Please add any questions for Dr. Tabdina to the Q&A presented to the audience. I have the pleasure now of introducing our next speaker, Veronica Barcelona, PhD, MSN, RN, FAAN, PHNA, BC. She is an assistant professor at Columbia University School of Nursing. Dr. Barcelona earned her BSN from the University of Michigan, her MSN and MPH from Johns Hopkins University, and her PhD from Tulane University School of Public Health and Tropical Medicine. Her NIH-funded research interrogates mechanisms and risk factors underlying adverse pregnancy outcomes with the goal of achieving healthy and safe birth outcomes for all. Dr. Barcelona.
Hi, thank you, Dr. Simonovich. Happy to be here today and to share a little bit about my work and this, specifically this paper that was featured in the special issue. I have no conflicts of interest to disclose, and I also should say that this work was supported by the Columbia University Data Science Center, as well as the Gordon and Betty Moore Foundation. Thank you. We're all well aware here that perinatal health disparities are significant and worsening in the United States, especially for Indigenous, Native, and Black birthing people. And few interventions have been proven to reduce disparities in pregnancy and birth outcomes. Even when women are highly educated, have private health insurance, employed, all the potential confounding factors, these increased risks persist and lead to the conclusion that the root cause of racial and ethnic disparities in the United States is racism and bias. Next slide, please. So previous qualitative studies have described the effects of racism in obstetric care, and Black women who experience racism and discrimination have fewer clinician-patient interactions than white women, receive poor quality of care, and report a lack of autonomy, poor communication, and feeling unheard. There is also a growing body of qualitative work involving clinicians. Clinicians report holding biases against pregnant women of color, especially Black women, and stigmatizing language may be a marker of unconscious bias. Next slide. So what is stigmatizing language? It's defined as language that communicates unintended meanings that can perpetuate socially constructed power dynamics and result in bias. Previous studies have been done on stigmatizing language in internal medicine and substance use and addiction settings. And stigmatizing language was found to be more prevalent in the electronic health records of Black and Latino patients, and also may result in the transmission of negative attitudes from one clinician who writes stigmatizing language in the note, and then the next clinician who opens the record and reads that. This work is especially important in light of the new 21st Century Cures Act, allowing patients to access and read their own EHRs. If patients read stigmatizing language in their health record, this can contribute to mistrust and result in women being less likely to seek care. There is also some emerging evidence indicating that stigmatizing language may be associated with poorer pain control and worse mental health for those experiencing stigma due to substance use disorders. Studies linking stigmatizing language to health outcomes have not yet been done in the context of perinatal health, and that's part of the larger work that I'm doing with this study. Next slide, please. So what are the implications of labeling patients in written documentation? Well, it can hurt patient trust and the clinician-patient relationship. For example, one type of stigmatizing language is labeling the patient as difficult. When this is done, clinicians may be more likely to call child protective services for parents arguing, for example, in the postpartum unit, let's say. This may be especially harmful as we know that Black and Hispanic patients have higher rates of CPS involvement, and researchers have recommended using other methods of de-escalation instead. Next slide. So given that background, I will now share with you the study that's featured for this webinar. We conducted a secondary qualitative analysis of 1,771 notes from the inpatient birth admission at 2 metropolitan hospitals from 2017. We looked at stigmatizing language towards patients, non-stigmatizing language, and stigmatizing language among clinicians. We used Krippendorf's content analysis of categorical distinction, and the categories we looked at came from our own pilot work as well as others previously published studies. We also explored new language categories. Next slide. We re-annotated the previous 1,117 notes and also looked at 583 new notes until we achieved saturation. We found previously identified categories of stigmatizing language, shown here, and expanded the unilateral decisions category to include paternalistic or authoritarian language that reinforced the patient's place in the care hierarchy. We also added a new stigmatizing language category, unjustified descriptions of social and behavioral risks, which contain language that unnecessarily pointed out marginalized identities, such as skin color, sexual orientation, age, or body size. For example, where this demographic information was already present in the structured fields, then restated again for emphasis in the narrative notes. You'll note here that power and privilege language is noted as stigmatizing. We have previously published our theoretical basis for this, where we note that both types of language are needed to uphold a hierarchy where the ideal people to reproduce, who are the ideal, quote unquote, ideal people to reproduce in our culture. And we found examples of non-stigmatizing language as well, and the 2 categories were positive and preferred language and the patient exercising autonomy for birth. Finally, we identified new categories of stigmatizing language among clinicians, where clinician blame or structural care barriers may have prevented optimal care from being delivered. Next slide, please. Here are some examples of quotes from each category in the study. An example of disapproval from the notes. Patient shared she was not in a serious relationship, quote unquote, one-time thing, and used condom when became pregnant. An example from the difficult patient category. Poor effort with pushing, patient complaining of headache, patient refused referral for lactation services. An example from the unilateral or authoritarian decisions category. Advised if there's continues to be yelling, CPS will be contacted. And questioning patient credibility, denies having missed appointments, information incorrect. These categories express disbelief in the patient's report of their current history or their physical status. The unilateral and authoritarian decisions category upholds the hierarchy centering the clinician and not the patient. Difficult patient refers to non-adherence with the clinician's plan of care, and refusal of referrals or services. And disapproval is indicative of behaviors of the patient that are not in line with healthcare provider expectations. Next slide, please. Further stigmatizing language categories included power and privilege language, and these are related to identities related to psychological or social status. For example, the patient was a 26-year-old Hispanic woman appropriately groomed and dressed for hospital stay. Unjustified descriptions of social or behavioral risks. Examples include toxic habits, social disarray, substance abuse, obesity, and mental retardation. This is documentation of social risk factors that could contribute or reinforce marginalization of patients, including drug use, domestic violence, and teen motherhood. Next slide. We also have examples of positive or preferred language, defined as non-stigmatizing language that uses more neutral and patient-centered language to convey the patient's point of view. Examples of these are patient desires an epidural, declines genetic consult. And finally, we have language that describes the patient exercising autonomy for birth. Amniocentesis offered and patient declined, stating she would not terminate for Down syndrome. Next slide. Finally, we also have some examples of stigmatizing language use among clinicians. This is a new category and infrequently observed in the small sample of notes that we reviewed. First, for clinician blame, these are notes that describe issues in care that can be attributed to another clinician, often nurses. An example, called to patient bedside because patient had infiltrated IV not infiltrated, flushes easily. We have examples of structural care barriers, defined as describing care that was not delivered in a timely manner due to staffing or other issues. Patient would like a bilateral tubal ligation, unable to do today due to census and physician coverage in labor and delivery. Another example, unable to staff nursing placement of epidural and triage, requested notice when there's enough nursing staff, and when patient can get into labor room, still in triage secondary to census, will likely augment labor. Next slide. In conclusion, we generated a spectrum of stigmatizing and non-stigmatizing language categories and identified new categories of language documented in hospital birth settings. We also confirmed previous pilot study findings by identifying most of the same categories again. Next slide. What are the implications of this work? Well, in terms of education and training for clinicians, we know that we can work to educate clinicians on the harms of stigmatizing language and provide examples. We can promote the increased use of shared decision-making models and promote the use of strength-based, patient-centered language. In research, our group is continuing to work on analyses looking at associations between stigmatizing language and maternal morbidity outcomes. And also, we're thinking about ways to incorporate flags in real time in the EHR to interrupt bias. And that's all I have for today. Thank you all, and I look forward to the moderated discussion.
Thank you so much, Dr. Barcelona. This was a very insightful presentation. Again, if any of our audience members have any questions for Dr. Barcelona, please feel free to put those into the Q&A. Our fourth and final presentation features co-principal investigators of a study describing opioid recovery among women. Dr. Jessica Zimlak and Nicole Matson, assistant professors at Marquette University College of Nursing. Dr. Zimlak is a community-engaged nurse scientist whose program of research focuses on social structural determinants of sexual and reproductive health among marginalized women, including those who sell sex and use drugs. She leads innovative projects on women's health, PrEP access, telehealth, and health equity. Dr. Nicole Matson focuses her program of research on facilitating optimal wellness of women and children impacted by substance use disorder and sexual and reproductive health of women in recovery. Welcome now, Dr. Zimlak and Dr. Matson. Thank you.
Hi, we are thrilled to be here today. So my name is Dr. Nicole Matson, and I'm going to be presenting with my colleague, Dr. Jessica Zimlak. You can advance to the next slide. We just wanted to mention that there are no conflicts of interest to disclose. Next slide. Similar to some of the other presenters, we wanted to begin our presentation by defining two key terms to set the context of our study that we'll be talking about. The first term is sexual and reproductive health. So for the purposes of our study, we use the World Health Organization definition of sexual and reproductive health. They provide a comprehensive definition that looks at aspects beyond contraception and STI prevention to include broader terms such as sexuality and healthy relationships. Next slide. And the second term we want to talk a bit about is recovery. And so for the purposes of our study, we use the definition from the Substance Abuse and Mental Health Association on what is recovery. And we see that recovery is a very individualized process and a journey. This journey that an individual goes on may begin with initiating treatment. Treatment interventions may include things such as medications like buprenorphine or methadone, or there may be various programs that someone engages in, like a 12-step program or a Narcotics Anonymous program. Next slide, please. So both recovery from opioid use disorder and reproductive health are regulated on state and local levels in the United States. Treatment programs that involve the use of medications for managing opioid use disorder are subject to laws and regulations that can affect a woman's engagement in their recovery experience. And for example, this could be ways that an individual obtains their medication. It could be related to who is able to prescribe them the medications for opioid use disorder. Additionally, we know that addiction has historically been viewed as a moral failing versus our more current understanding of substance use disorders being a chronic health condition. And so this viewpoint has impacted the way that drug policies have been written and how they've been enacted. So under these regulations, the unique needs of women are almost never taken into consideration. The legal ramifications related to drug use during pregnancy can vary by state of residence, and it can also vary from civil to criminal penalties. So for example, as of 2022, 23 states and the District of Columbia have laws that identify substance use during pregnancy as child abuse. Women of reproductive age in recovery also have to navigate policies and laws related to their sexual and reproductive health. So for example, the Affordable Care Act mandates that health plans provide birth control and family planning services without cost. However, the ability to access abortion care now varies by state following the Supreme Court decision to overturn Roe v. Wade. Next slide, please. So given some of the stark reproductive health disparities that we see among women with opioid use disorder while they're in recovery, it was important for us to explore the perceptions of policies and laws on sexual and reproductive health among women in recovery from opioid use disorder. Next slide, please. So we used a community-engaged qualitative descriptive study design. We sampled women who self-identified as being in recovery from opioid use disorder. And we partnered with a community organization who serves women with opioid use disorder, as well as work closely with a woman with lived experience of being in recovery to structure and develop the content and format of our interview guide. We then conducted one-on-one telephone interviews that lasted approximately 45 to 60 minutes. And then we analyzed the data looking for themes based on the data from our participants. Next slide, please. We had 22 women participate in our study. The demographic data is listed on the slide there. We can see that 55% attended college or were college graduates. We had a sample of highly educated individuals. 76% had been pregnant. And it's also important to identify that all participants lived in Wisconsin at the time of the study as well. Next slide, please. So we identified 3 themes in our study, and as we move through the results, we'll be presenting one result at a time, and we'll present the theme, talk a little bit about the theme, and then also provide some direct quotes from participants as well. Next slide. So the first theme we identified was barriers to opioid use disorder treatment and recovery. So when participants were considering their experience with policies, with laws, some participants indicated that the regulations related to access to treatment and the criminalization of drug use were often barriers to their recovery experience or to their recovery journey. So as we see in the first quote, this participant is highlighting that the shared lack of resources, such as beds and treatment centers, was a barrier to them receiving the desired level of care that they were looking for. And that this barrier they felt was not equally faced by men as it was for them. Other participants described their frustration with the criminal implications of opioid use disorder. So we can see this in the second quote. And at times, the criminal implications, for example, being in jail, led to periods of forced sobriety. However, that forced sobriety was not the same as like the beginning of a path to treatment. Next slide, please. Our second theme was pregnancy as a gateway to treatment and recovery. And here we heard individuals talk about how pregnancy was a time period where they felt highly motivated to engage in treatment or to begin their recovery journey. And we can see that in that first quote. Other participants felt that being pregnant made it easier for them to access different treatment options. For example, inpatient treatment or medications for opioid use disorder. And so we see in the second quote this in the sense that there's an increased ability to access these options. So pregnancy varied among participants as a motivator to begin engaging in their recovery process or treatment, or as a facilitator to accessing different treatment options that may not have been accessible when they were not pregnant.
Our third theme is the Dobbs effect. Our interviews happened about a year after the Dobbs versus Jackson decision and that decision constrained reproductive autonomy. And this featured really prominently in participants' descriptions of their health and recovery. As Dr. Mattson noted, our team is located in Wisconsin, and so were our participants. Women in Wisconsin lost access to abortion care immediately after the Dobbs decision. Abortion care has since resumed in Wisconsin at this point, but it's important, particularly with this theme, that the timing of our study was such that abortion was very much a feature in the local news and in online communities. And it also featured really prominently in responses of our participants when we asked how women felt about policy and laws and their impact of women's health and recovery. Participants in our study described feeling that an unintended pregnancy would threaten their recovery journeys. Recovery often involves a shared community, a community with groups and peers. Participants described how in their peer groups they saw women around them fall apart or relapse when experiencing an unintended pregnancy without being able to access abortion care locally. Participants in our study really closely guarded their recoveries, and the overturning of Roe v. Wade and the lack of abortion care access locally was an unintended consequence and posed a real threat to women's recovery journeys. Next slide. Our study has important implications for practice. The opioid crisis has meant that the number of reproductive age women in recovery is constantly growing. There are continued gaps in education and the provision of resources regarding sexual and reproductive health for women in recovery. Nurses are trusted sources and are present across different healthcare settings, and therefore can be an important resource for accurate sexual and reproductive health information and resources for women in recovery. Medication for opioid use disorder, these are medicines like buprenorphine, are the gold standard of treatment for opioid use disorder. There's been an expansion in who is allowed to provide these medications. Many women with opioid use disorder are reproductive age and will be engaging with women's health providers for various concerns. Women's health providers, therefore, could be a valuable resource for providing medications. Currently, only 2% of these providers offer medications for opioid use disorder. Supporting practices that increase the ability of these providers to provide medications is important. And finally, women described experiencing barriers to navigating sexual and reproductive health care that was not located with their recovery services. Practices that strive to co-locate, meaning locate recovery and sexual and reproductive health services together, are an important practice consideration. Next slide. Our study has important implications for future research. We are now in a post-Dobbs world where many women in different areas of this country do not have reproductive autonomy. We know from past research that there will be negative impacts on women's health with restricted access to abortion care. More research will be needed among women in recovery regarding sexual and reproductive health and mental health in a post-Dobbs world. Our study participants perceived they had improved access to care when they were pregnant, and this is not necessarily aligned with other research in other geographic areas. Therefore, a national study exploring pregnant women's experiences accessing recovery services is needed. Finally, there were COVID-19 related policy changes regarding who and how medications for opioid use disorder can be delivered. We need research to explore how these changes impact specifically women in recovery. Next slide. This research explores how women experience the complexity of policy and laws, but it also highlights some important consideration for future policy and advocacy. There is a need for policy and laws to move away from the criminalization of the chronic disease of opioid use disorder and focus on public health science-based best practices, such as medication and harm reduction practices. We have to continue to be a voice advocating for reproductive autonomy. Our study highlighted one of likely many to be seen unintended consequences of constrained reproductive autonomy. Women in our study were destabilized by this and they saw their peers relapse. As nurses, we're really well positioned to be advocates. There are 4 million nurses in this country. We're the largest discipline in healthcare. We could be powerful policy advocates for the health needs of women in recovery. Next slide. Just want to briefly acknowledge some of our limitations and some things to consider when you consider the results of our study. Next slide. And we want to close with gratitude. We are very grateful to our participants. The topics we discuss are sensitive, and we're grateful to their generosity for trusting us and sharing their stories with us. And we wanted to acknowledge our funder. Next slide. And we've included references which are also available in our published work. Thank you.
Wow, I want to extend my thanks and gratitude to all the authors for their thoughtful and engaging presentations. I learned a lot, really meaningful and important work. So thank you. We are at the phase in our webinar where we're going to ask some question and answers of the guest editors and of the authors here. And so I will start this off by asking the guest editors who, like Shannon, Dr. Simonovich, she mentioned this has been 2 years in the making in relation to the vision and all of the work that goes into developing a special issue or content for a journal. And I'm curious, what was the process, involved and for selecting the papers for this special issue? And how did you work with the authors in the process?
Thank you for your question. It has been such an honor to lead this effort alongside Dr. McLaughlin-Bell and Dr. Rossman over the last 18 months or so. It really began with formulating a call, and we are really grateful to the editorial team, Angie Hartley and the others, to really help us fine tune that. We wanted to create an opportunity for scholars in our field to help highlight how complex and heterogeneous it is trying to study women's mental health across the life course. So that really began with issuing a call for abstracts, using all of the social media channels and using all of our networks to help spread the word. Kelly, would you like to pick it up from there?
Sorry, I was just putting into the chat the link to our information for authors. So as Shannon was mentioning, we really worked hard to make sure that we got this information spread out on various networks through LinkedIn, Facebook, soliciting personal contacts and others that we thought might really be able to speak to some of the broad topics discussed within this presentation or within this special issue. And so working with the authors or having people submit those abstracts and their manuscripts and really going through the rigorous process of being reviewed by JOGNN reviewers was very, very a long process, but a very necessary process when we want to have rigorous research. And so I think we were able to put together a very robust and rigorous issue here.
Yeah, and it was a very competitive process. We received more interest than we had available to publish, but we really looked at all of the submissions as a team of 3. And then through the formal peer review process, we do thank all of the JOGNN reviewers for their feedback to really highlight the breadth and depth of this topic and really create a platform. JOGNN is such an incredible platform for colleagues in nursing and in other allied health sciences. And we really wanted to take advantage of that to really highlight projects that we thought would move the bar forward with regards to policy, practice. And we really see the JOGNN readers as a huge group that can help to improve screening and treatment and even just, appropriate, respectful care of women across the life course, particularly with regards to their mental health. And so we wanted to highlight all the research that we could that would help drive that forward.
I'd like to add, I hope that the writers on this call felt that they were able to talk to us as guest editors, but also Dr. Edmonds is very approachable. And so for anyone in the audience who's looking to publish in the future, please don't be afraid to reach out to any of us if you have any questions regarding how to publish within JOGNN.
Thank you so much. I have a question. I'm going to start with one question for Dr. Ahmed. Your research really highlighted how cultural norms and stigma can dictate how women perceive and seek mental health care, often leading to underdiagnosis, limited support, untreated trauma, especially in communities where mental illness is highly stigmatized. And so I'm thinking really specific to the Muslim American women living in the US. How can we work to reduce the stigma?
Thank you very much. And it's $1 million question because I think it's globally an issue, as I stated earlier, in our community and culturally, it is it's faith and being a mother is very closely related. And if you are not being a fit enough mother or thankful enough or grateful enough or strong enough, you're not being thankful enough to God for having blessed you with this blessing. So I think to move from that concept of this is not being thankless, but it's about being vulnerable to an illness, which could be a clinical issue, and promoting that concept of how postpartum depression or clinical depression and clinical anxiety are health issues, not necessarily a matter of weak faith. That kind of educational approach is very essential when it comes to women, not just in the US, but around the world of the Muslim faith.
Mm-hmm. Thank you so much. My next question is for Dr. Barcelona. I'm curious what motivated you to explore use of stigmatizing and non-stigmatizing language in hospital and birth settings.
Yeah, thank you, Dr. Edmonds. Previously in epidemiologic research, there has been decades and decades of work done in maternal health to try to understand the reason for racial health disparities. And this work has over and over again said that we know who has worse health outcomes, yet there were no interventions that were able to really bring down that gap. So I wanted a way to address racism and bias as the primary exposure leading to these disparities. And I wanted to do that at the institutional level. So I thought if we can identify the policies, the structures, the education, the culture at the hospital level, at the unit level, that are reinforcing bias, and we can identify bias and measure it, and we can show that it's associated with poorer birth outcomes for marginalized folks, then maybe that's one way to help mitigate these disparities and create a more equitable birth culture that's more supportive to all women in this country.
Thank you. A question for Dr. Tabdina. In your work on racial categorization in women's mental health research. My question is, what are the potential consequences of continuing to use inadequate racial categories in mental health research and practice for multiracial women's mental health outcomes?
If we are unable to disaggregate large data to describe patterns by race and ethnicity as self-ascribed, we are missing a larger and larger subset of the US population. And what we're going to see is that our findings are going to stop describing patterns. If our groups are going to become too homogeneous within groups, and we will have greater within group difference than if we simply disaggregate, look at these smaller subsets, and describe patterns for what they are. Thank you for the question.
Thank you. Dr. Zemlak and Dr. Matson, I'm curious, this really impactful work on women in opioid recovery. I'm curious throughout the process of conducting the research, how your own perspective on opioid recovery and reproductive health changed or evolved.
Well, I think kind of the way that we thought about our own perspective during the research, I'll address that and then a little bit of my own personal piece. I think it was very important because as we wanted to carefully consider our identities as women that were of reproductive age, that were also living in the same state and impacted by the same changes in policies and laws at the same time as the individuals that we were interviewing and collecting data from. So we wanted to make sure that through the course of the research that we made sure to really take time every time we got together to go through data analysis to think about the ways that our own lived experience may influence our understanding of the data that's coming up, and make sure that we were able to kind of partition that and recognize this is what our individual thoughts were, and make sure that we were really staying true to the data. One thing that I think personally, as I went through conducting the research and evaluating the data as we were looking through it, one thing that I was really struck by was just the importance that recovery was to the individuals that we were talking about, and how closely guarded they kept their recovery, to the point where they were willing to go to some pretty big extremes to safeguard their recovery journey when it came to being able to have some sort of control over their reproductive health, whether that be having like getting like an intrauterine device placed, considering hysterectomies. So they were really safeguarding their recovery journey and recognizing how impactful maybe like an unintended pregnancy could mean, or what that could mean for them in their recovery journey. So I think that was something that I personally took away.
Thank you. I guess I have a question maybe for all the speakers, and perhaps people could chime in. Thinking about the future of women's mental health care, what future areas do you think will be crucial for advancing this work?
I could take a spin at that first if you'd like.
Great, thank you.
Yeah. I think kind of building on what Dr. Matson mentioned, one of the things we talked about in our research was the growing number of women that are going to be entering into recovery as the opioid epidemic persists in this country. The numbers are only going to increase. So I think for us, what the future research holds is really thinking about the unique needs of women in recovery and the unique mental health needs of women in recovery, because what we've seen previously is that there really hasn't been, as much as probably we had hoped, a gender-specific focus perhaps on the unique recovery needs and mental health needs of women who are in recovery, and certainly not on the sexual and reproductive health needs of women in recovery. So that's one thing I can imagine that we'll need going forward.
Thank you. Other panelists?
Just put in a plug as a public health nurse that, in these times, I think it's more important than ever that we band together as clinicians, as nurses, and advocate politically for policies that support women. And this includes everything from expanded healthcare coverage, universal healthcare coverage, social policies to support motherhood, such as paid parental leave, and community-based approaches to maternal health support in the prenatal and postpartum periods. If we continue to criminalize mental health, substance use, if we continue to have poverty criminalized, we have structural racism, we can't achieve optimal physical or mental health for women. So I think continuing to resist and to be politically active is going to be extremely important.
Thank you. And I think that's an excellent way to end this question and answer period of the webinar. And I thank all of you and turn it over to Dr. Shannon Simonovich.
As we close out today's webinar, we'd like to thank you all who are joining us synchronously and those of you who will watch this online asynchronously. We'd like to thank all of our incredible featured authors, Dr. Tabdina, Dr. Ahmed, Dr. Barcelona, Dr. Zemlak, and Dr. Matson. I'd like to thank my co-guest editor, Dr. McLaughlin Bell, and our host today, Dr. Edmonds. This is a reminder that the full January 2025 special issue is open access and available for download from the website. Please feel free to reach out to myself or Dr. McLaughlin Bell if you have any questions after today's webinar. Thank you so much.